So what I thought I would talk about today is, excuse me, bypass surgery. And the reason why I wanted to, why I like talking about this in general is because it's really not just about bypass surgery. It's more about what, how we as neurosurgeons practice and how we can practice a little differently if we think about what we do in a different light. And so that's really what I'd like to stress upon you. Bypass is really a vehicle or a metaphor, but really this is about finding ways for all of us to evolve our practices and to really push ourselves so that we take ourselves and stretch ourselves to our limits. So I'm going to draw upon my case experience, which you can see here. It's now 23 years worth of a lot of cases, primarily focused on vascular and skull-base tumors. These are the vascular cases. And, you know, I can feel pretty good about my accomplishments and my volume when I look at these numbers. But if you take a look carefully at this slide, what you see here is that the aneurysm curve is nicely, steadily climbing over time. But if you look to the right and break down the trends year by year, what you see is that we've actually reached a peak in the aneurysm volume and we're on the decline. And that's a really kind of distressing insight for me because, you know, I think all of us work hard to develop our reputations and develop our technical skills so that we can become better surgeons. And in theory, if we're successful, then we should be getting more patients and our practices should be thriving. And what this curve tells us is that we can't really beat or fight these market forces that are out there. They're too overwhelming. And even if you do a lot of hard work and a lot of good surgery, there are forces on the endovascular side that are changing our practice dramatically. So when I saw this, you know, one of my reactions was to try to capture the things that I had learned about aneurysm surgery and put them down in a book. And that's one of the lessons I'd like to impress upon all of you is that the pen is mightier than the scalpel. What you do in the operating room helps one patient at one time. But if you can take your experiences and put them together in teachable lessons and things that will help many others over time, it's a much mightier thing. So I've tried to do that with my writings. These are some of the books I've put together. And I really want to focus on a couple things. The first is that, you know, the book on aneurysms was really a reaction to that curve. The sense that these cases were dwindling. And I wanted to get it all down on paper so that people in the next generation would understand or would learn what I learned. And I always felt that we could do a better job in breaking down our operations into these steps. I chose the metaphor of a dance because if you can take a complex thing like a dance and break it down into these ordered steps, then it would become understandable to everybody and all could do it. We put together some beautiful artwork with Ken Probst, my illustrator, and you can see the dance steps on the Sylvian fissure here and getting the dissection down to this middle cerebral artery aneurysm, really breaking down the different thoughts and ideas that go into safely exposing this aneurysm, getting proximal control, finding the different branches that come from it, and ultimately clipping. But when I started thinking about the giant aneurysms, the really complicated aneurysms, and looked at my series on these, what I came to was that maybe there's some line that we cross with the giant aneurysm where it no longer becomes just a simple aneurysm and it has to be treated differently. And just to illustrate that point, I want to show you this case. This is a giant MCA aneurysm. You can see here, I clipped this with what I call a picket fence, which is this stack of clips. But here on angiographic follow-up, you can see it recurred. It recurred right at the base where those tips of the clips reconstructed that bifurcation. So in this operation, what I do is I bring in a saphenous or a radial artery graft, I plug it into one trunk, swing the trunk over to the opposite side, and then revascularize that opposite trunk. So both of these trunks are revascularized with a single high flow graft in what I call a middle communicating artery. And that's what I did for this picket fence. So here, now, when we look in the sylvian fissure now 5 years later, you can see all the scar tissue and the recurrence there. This is a view of the external carotid artery. So this shows you just the standard external carotid proximal anastomosis for this radial artery graft. Here we are back in the sylvian fissure, and this is the temporal artery coming out of the aneurysm. So this is the temporal trunk, and I'm going to sew here the radial artery graft into, into that temporal artery. And it's just an enticide anastomosis. You can see 9-0 suture, good flow in this IC green video angiogram. But here's where it gets interesting. This is now a clip on the outflow from the aneurysm. I'm cutting the trunk off of the aneurysm, and you can see that I'm repurposing that dead end stump as a donor. It's not typically something that we use as a donor, but if you think about it a little differently and swing it over here to the frontal trunk, here's the first suture line, you can see how it reimplants very nicely on the other side of this aneurysm. And now we've reconstructed that bifurcation completely. This is a view on the back side of the aneurysm just to show you lenticular striates. It's going to keep me from completely trapping this aneurysm. It's just a distal occlusion. But now you see the radial artery graft. It vascularizes both of the MCA trunks, and we've created this nice middle cerebral circulation from the high flow graft. So what does that tell us? It's basically an example to say that when you get to giant aneurysms, they're a completely different entity. They're no longer just a simple small aneurysm that you can put a clip on, but there's something that requires a completely different strategy, and that strategy is bypass. This is my giant aneurysm series, 235 cases, if you look at the numbers of bypasses that I've done for those giant aneurysms, it's 44%. So nearly half of these are treated with a bypass. So that's why I think it's important. This is not just some esoteric topic within neurosurgery, but it's really, you know, if you're climbing that mountain to get to the pinnacle of the hardest cases that we do, I think you really have to acquire the bypass skills, and that's why this is important, at least as I see it. So I put together this book, and one of a couple things I wanted to do, but I wanted to develop a taxonomy for bypasses. I wanted to develop a system of symbols that could allow us to take ideas and translate them into constructs. And I also wanted to push these intracranial to intracranial techniques. And the metaphor that I chose was architecture. I lived in San Francisco for 20 years. This is a view from one of my morning runs in Kirby Cove. And when you get down to the beach, you can look across the Golden Gate and see the skyline of San Francisco. And this bridge is a great metaphor because you know, it's really meant to connect Marin County to the city. And if you look at some of the earlier designs of the bridge, they were these enormous trusses. They looked terrible. They were very unsightly. And the engineers decided that they wanted to instead make this a statement about their engineering abilities and a statement about aesthetics. And so they changed the design. At the time, this was the largest suspension bridge in the world. These towers are 750 feet tall, the tallest towers at the time. The span of that bridge is 1.7 miles across, and it's about 80,000 tons of steel that's suspended by those little cables, which you can barely see. And the point is, it's a very elegant construct. It looks, even to this day, it's over 75 years old. It looks very modern, it looks very bold, and looks very beautiful. If we look around the world and look at other architectural symbols, this is now the Freedom Tower in New York, which has become a symbol for American resilience after a terrorist attack. If you look in Spain, this is the Basilica La Familia in Barcelona, and it's Antoni Gaudí's masterpiece, which he used to change it up. He used these columns that were branched, that were like trees. He used the parabolic shapes rather than these circular shapes. And when you look up at the nave from below, it's just this beautiful site that you see here. If you look to Sydney, Australia, this is the Opera House, and you can see these concrete shells that are created and stacked and tipped upward. And it's built out on the water so that this opera house looks like a sailboat as it's heading off to sea. And one of my favorites is Frank Gehry, and this is his museum in Bilbao, Spain, showing the use of these really abstract shapes and forms and the use of titanium metals that look like the scales of a fish as this fish swims up the river. So the point is that each of these artists have chosen to make a statement with their work and not just build a structure or a shelter or a building. They've chosen to make a statement about art and about what they believe in. And that's really how I see bypass. You know, we have an opportunity to not just do the plumbing, but to make these statements about our profession, about our craft. It's a way to be creative, express personality, to express our passion for our work. And, you know, I think if you're going to embrace this way of practicing, it really demands a lot from all of us as surgeons because we have to be perfect. Let me talk about blueprints. This is a house, and obviously if you're gonna create a contemporary house or any house really, you go from a vision, some idea in your mind, you have to then translate it to a set of blueprints, and then you have to communicate through those blueprints to your construction crew how to actually put up that house. And here's an example of the completed house. And we didn't have that. We don't have that in bypass surgery. And so one of the things that I wanted to do was to create this language of symbols so that we can actually create blueprints. So this is what I put forth in the book. These are different symbols for the anastomoses. You can see here, this is an end-to-end anastomosis. A side-to-side is over here. These are various end-to-sides, different ways of representing aneurysm occlusion, different ways over here of representing grafts and donor vessels. And over on the right, you can see the various wiring diagrams for the middle cerebral circulation, the anterior cerebral circulation, the basilar circulation, and the pica territory. And what you can then do is you can create these blueprints for the bypass that you have. So if you're trying to think of how you want to rebuild the circulation, these are the symbols you can use to sketch it out. Now, it's hard sometimes to actually do the drawings because, you know, that requires a whole different set of tools. And so another thing I was interested in doing was to create a code, essentially taking over here on the right, you see this sequence of alphanumerics, basically these addresses for the different segments of artery. And you can essentially put an address on every segment in the cerebral circulation. And when you use those addresses, you can then describe a very complicated bypass like this one with a code. Here's our code right here in the middle of your screen. It's this A1 ACA using an SVG, a saphenous vein graft, to the middle cerebral artery. And this is a double reimplantation technique. So you see the plus symbol here and the two M2s as our recipients. This code really tells you everything you need to know about what you're seeing in this picture. You know exactly how the connections are made and what has been done. Here's our symbol. This is our blueprint up here. You can also express the bypass through the blueprint. And here's our angiogram. So if you were trying to understand that, this code would really help you decipher. So that's the symbols and the codes. This is the taxonomy. I have broken these bypasses down into 7. starting with the traditional ACIC bypass is our first generation bypass. That's the STA-MCA bypass. That's your occipital artery to pica bypass. All of the simple ones that most of us do fairly routinely. The second class or second generation is the ECIC interpositional graft. And these came around in the late 60s with guys like Thor Sundt, who used the cervical carotid artery as a donor to increase the flow, but it did require longer grafts, tunneling the bypass, and some compromises in terms of patency. These next four groups of bypasses here are all of the what I call the AICA or intracranial bypasses. It's the reimplantations, the in situ side-to-side bypasses, the Reanastomosis, the short jump grafts that go from an intracranial donor to an intracranial recipient. The seventh category down here at the bottom is the combination. So combination bypasses are when one bypass doesn't do it and you need multiple. And so it could be any of the above. It could be one ECIC and one in situ, or it could be two ECICs, a double barrel bypass, but it requires a multiple. And it could be two, it could be three, it could be however many is necessary. So those are the 7 bypasses. One of the ways that you can use the 7 bypasses is first to really get a handle on where your aneurysm is located. If you look at the different types of middle cerebral artery aneurysms, it's important that we really clarify a pre-bifurcation versus a bifurcation versus some post-bifurcation bypass or aneurysm. And then when you have the combination of 7 bypasses here on the vertical axis and the different aneurysm locations here on the horizontal axis, then you can kind of lay out your blueprints and decide or see all of the different bypass options that you have to choose from. And that can really help your thinking and your selection. You can also walk yourself down an algorithm. You can walk yourself from the top here, some complex MCA aneurysm, ask yourself a series of anatomical questions and lead yourself to your selection for the bypass. So let me show you an example of that in action. This is a giant MCA aneurysm. And for this one, our algorithm would say this is one that we need to revascularize completely by recreating the bifurcation. So we have to expose the 2 trunks that come out of the aneurysm, and that's what you're seeing here. This is the temporal trunk over here. This is the frontal trunk over here. The aneurysm is up at the top of your screen. And I'm going to use the A1 as a donor. So I'm going to do this without using the neck. I'm going to not use a tunnel. I'm going to just use the A1, which is a tremendous donor because it's really right there in the sylvian fissure. When you split the fissure, you come right to it. And it's a very vigorous donor because it sits right next to the carotid terminus. So the flow is really substantial. This is a view just showing trapping of that donor segment. And this is a very nice arteriotomy scissors that I like to use for these deep bypasses. This is the bypass, the donor site going in. This is the 2 anchoring sutures that anchor the, in this case, I believe it's a radial artery. No, this is a saphenous vein, sorry. But this, you can see some of the stitch work here, sewing down in this deep kind of perichiasmatic space of the A1 anterocerebral artery. You can see a nice suture line there on the front wall. Tying this down, we can flip the artery. This is a view into the lumen. And now we're sewing the back wall. I'm going to jump ahead a little bit here. Pardon the fast forward, but here, now I've taken you to the aneurysm itself. The saphenous vein graft is lying in the sylvian fissure. I'm making my arteriotomy here in the saphenous vein graft. And what I'll do here is, in order to reimplant that frontal division, I'm going to do a side-to-side anastomosis. So this is 2 arteriotomies in the mid portions of each of these, the vein graft and the trunk. And we can bring them together with this 9-0 suture. And this will be a side-to-side reimplantation. And it's side to side because we need to keep the other end of this graft ready for the temporal division as our third anastomosis. So it's a combination bypass. This is now an in situ style side to side anastomosis. You can see I'm showing interluminally. And these arteries come together very nicely here to create our donor and recipient relationship. I'm going to jump ahead again here as we complete the outer wall of that anastomosis. You can see it coming together. And this finishes up very nicely. Here's our completed side-to-side anastomosis. You can see the end of the graft there. We can reapply the clips so that we immediately reperfuse that trunk. And now here's the end of the saphenous vein graft. Here's the temporal trunk as it comes out of the aneurysm. And here's our anchoring suture. You can see the stitch work now running alongside the inside of the vein graft and into that deep wall of the temporal artery. And this joins the vessels. I'm going to just do a running continuous all the way around the horn here. So I transition to now from interluminal here, which you're seeing as I tighten those sutures up. We're going to transition now to an extraluminal suture line right here. And we continue that around the corner. And let me jump ahead again. Here now is the completed anastomosis. So now we've got an A1 donor, we've got an M2 reimplantation, we've got a second M2 reimplantation, and now we can use trapping clips to isolate this aneurysm. So the aneurysm is completely trapped. You can see the 3 clips in there. There's good flow in the bypass. You can see all of the MCA vessels lighting up. The aneurysm is completely dead. I'm going to just go inside the aneurysm and suction decompress here. And as this aneurysm deflates, I'm going to do a little clip readjustment to free up some lenticular strides, which you can see on this yellow 560 right here. These were initially trapped between the trapping clips, but I've released them. They now perfuse nicely. And this now completes the bypass. This was that example that I showed you of the code, of that blueprint that had both the blueprint and the code. There it is. You've seen now the case, and you can see how the blueprints and the code really nicely express exactly what was done in the surgery. So let me move along and just talk about this idea of evolving the bypass craft and in a greater perspective, just sort of finding ways to evolve our practice of neurosurgery. I mean, the idea here is that you may not be out there doing complicated bypasses like I'm going to show you here, but if you're a spine surgeon and you do things the same old way, but have a better idea to be more minimally invasive or to develop a new device that's going to change the way you fuse the spine or correct the deformity, this is what I'm talking about. This is my challenge to you, is to think of ways that you can look at your practice and evolve what you do in ways that help all of neurosurgery. So let me talk about this. This is AICA Bypass. When I wrote 7 bypasses, I really didn't pay any attention to AICA. You might have noticed that there wasn't a wiring diagram for the AICA territory. There weren't a lot of cases on AICA bypasses, but I got to thinking, if this 7 bypasses framework is valid, I should be able to apply it to the AICA territory. And so what this illustration shows you is the 7 different bypasses that I did subsequently that demonstrate all the different types of the 7 bypasses. I'll show you an example or two. This is a AICA bypass, and it was in an elderly lady that had pontine compression, symptomatic pontine compression. And so just through a simple retrosigmoid exposure, you can see AICA there sitting right alongside of the 7th and 8th nerve bundle, which you see here. This is the aneurysm there. Now we're looking down lower at the vertebral artery. This is the V4 segment. You can see the rootlets of 12 draped over the top. And now what you're seeing here is PICA, which is the vessel at the top of your screen, and AICA, which is the one parallel right next to it, I was able to get those two to run side by side in parallel. So this here is going to be an AICA bypass. So PICA becomes our donor, AICA becomes our recipient, and our connection will be this side-to-side anastomosis. So here we go with the suturing, the handiwork. This is the anchoring stitch on one end. Here's the anchoring stitch on the opposite end. You see how I used a single clip on this end here to keep those arteries together. And now we get our intraluminal suture line going. This is the suturing that brings those inside layers together. It's a running continuous stitch, and we run it all the way to the other side. We tie it to the tail of that knot that's on the opposite side. And here's a view of the intraluminal suture line. As we round the corner here, we're now going to bring the outer walls over the top and together. So this is now an extraluminal suturing of the outer layers. And with that in place, you can see now PICA can donate blood flow to AICA, which gives us now the freedom to go to the aneurysm and do our trapping and decompression. So there's the bypass down here. Here now we've got a view of the aneurysm. This is AICA. Right here, as it comes out of the aneurysm, you can see the sixth nerve draped over the shoulder of AICA. And I'm going to first do my distal trapping. So that closes the aneurysm distally. Now I'm looking medially. I'm almost at the midline here. I'm pushing the aneurysm down, and I'm looking for the basilar trunk, and here it is. And I'm right at the origin of AICA right here, and you're going to see that there's just enough room there right here to apply our proximal trapping clip. So there's our proximal trapping clip. The aneurysm is now completely isolated. You can see that it's soft. It no longer pulsates. And now we can go inside and we can do a CUSA thrombectomy. Here's our CUSA. These are nice because they break up the thrombus very quickly, and all of that mass effect that was symptomatically compressing her pons has now been relieved. Here's the overview. You can see the trapping of the aneurysm up here. You can see the bypass down here. And I'm going to show you next an indocyanine green video angiogram that will show you this retrograde filling up this way to our clips, so that AICA and all of the lateral cerebellum now fill from PICA. And it's an AICA PICA in reverse. And this lady did quite well and a good result. Here's another example of an AICA bypass that I'd never done before. This was a mycotic aneurysm. You can see it here. This was a lady with HIV/AIDS. She had a subarachnoid hemorrhage. The aneurysm is distally located here on the lateral pontine segment of AICA. If you look over to the right, here's the 3D reconstruction here. You can see there's no neck to this. It's pretty much circumferentially diseased and needs to be either excluded or resected. And this is the video just to show you what that pathology looks like. Our inflow artery is here, and I'm putting my temporary clip on that to isolate it. We've got our distal clip there. And so I can now transect the pathology and remove that aneurysm completely. And if you look at where we are, I'm in the axilla of the 7th and 8th nerve. The 9th and 10th nerve are right here. And as you look down, you can see the 6th nerve in the very depths of this thing. So I'm almost to the midline of the pons. And oops. And here now, you can see the ends of the AICA have been brought together here. So this is an end-to-end reanastomosis. Very deep hole, working between the cranial nerves. These are the clips coming off. You can see the artery has been reconstructed nicely. This is just a little fibrillar unit to get the platelets to do their job. And now when we look at our indocyanine green, you can see the reconstructed AICA here, looping underneath the 7th and 8th nerve. Here's our postoperative angiogram. That reconstruction is somewhere right in here. And she did quite well with that. So that's the AICA territory. You can look at evolution in other territories. This was a paper from many years ago looking at 10 ACA bypasses. Most of them, 4 of them, were these A3 to A3 bypasses. And since that paper was published, in these subsequent 4 years, I more than doubled the amount of cases, and you can see all of the new different variations of the bypass that I did for that. And the in situ bypasses, they weren't just your traditional A3, which you see down here in the lower left. They were these unusual bypasses, A3 to callosal marginal to callosal marginal. Here's a double pica or pericallosal to pericallosal plus a callosal marginal to callosal marginal. And so a lot of different variations. These are just some pictures showing some of these different ways that you can do these anastomoses. The same is true with reimplantation. The ACAs run in parallel, so you can not only bring them together side to side, but you can also reimplant from left to right or from up to down. And so here are different examples of how arteries have been taken off aneurysms and swung over to the opposite side. These are some case examples just showing, you know, an aneurysm in the interhemispheric fissure that was transected and swung over to the opposite side. In this reimplantation bypass over here. I also have shown you on that earlier video the usage of A1 as a donor site intracranially. This has become a very nice way to replace the cervical carotid artery for a high flow donor vessel. And I've already shown you that. The Azygos bypass is yet another example in the interhemispheric fissure of using a short interposition graft and using an intracranial to intracranial jump graft to do this double reimplantation technique. So when we stand back and look, in the upper left, these are the 10 cases in that earlier publication, and you can see the different blueprints for all of those. These are the subsequent cases and the blueprints for those, and tremendous variation. I think really sky's the limit. It's just a matter of one's own creativity and one's own willingness to try a different bypass. Now, I want to talk a little bit about this concept of 4th generation bypass, because again, if we talk about evolution and talk about how we can think about our work a little differently and move it forward, 4th generation bypass would be an entirely different type of bypasses. I presented to you earlier the 1st, 2nd, and 3rd generation bypasses. Some would say that 4th generation bypass is really just flow diversion. That's why I put this picture here. But if you think about that early video that I showed you, this case here, and if you think about that reimplantation of the frontal division onto the saphenous vein graft, you can ask yourself, was that really a reimplantation? Because it was really more of a side-to-side in situ bypass. Because we did an intraluminal suture line, we brought these vessels together side to side. So it really calls into question what this really was. And if you look at the other bypass, that was an end-to-side reimplantation, but I sewed it from the inside. And that allowed me to shorten the graft, and that was a different kind of technique than what we're used to seeing. So the 4th generation really is in recombining these different techniques or these different constructs in unconventional ways. So for example, that last bypass, the reimplantation of the end of the saphenous vein graft to the temporal trunk, was what I would call a type 4A, because it's your conventional end-to-side anastomosis, but it was done with the in situ technique, or sewing intraluminally. So it becomes its own unique way of doing it. And you can see that in this picture right here. This is the in situ technique to create this end-to-side anastomosis. The type 4B is really doing things differently. So that's an example of using this side-to-side technique for reimplantations. If you put it in a table, you can look at the 7 bypasses that we talked about, but within each of these categories, there are ways to create these 4th generation bypasses, either through the use of an in situ technique or some unconventional construct here, the 4Bs, that allow you to reimplant or reanastomose or do these jump grafts in different or unusual ways. And I'll show you some examples of that. This is a pica aneurysm. What we're looking at here is a far lateral approach. This was a subarachnoid hemorrhage patient. This is our aneurysm here. And one way to do this would be to just trap this, excise it, and do an end-to-end reanastomosis. But when I looked at the anatomy, there are a lot of these little perforators that are coming off of this bend in here. And I didn't want to move this artery out of its position. So what I've done here is I've freed the proximal pica, and I'm going to do my end-to-end reanastomosis, but I'm going to do it with this end-to-side technique. So this becomes an unusual way to reanastomose this artery, pica to pica. And so I've got a stump here proximally. I've got the artery here distally, which I'm using to make a longitudinal arteriotomy. And so this will be an end-to-side anastomosis between those 2 segments of the same artery. So this is our anchoring suture. You can see how that nicely brings these vessels together. And I think, let me jump ahead here. This will just take you through some of the stitch work here, running the suture lines. But at the end of the day, what you see here is now the proximal pica here has been reimplanted on the distal pica territory. And when we do our indocyanine green, you can see this reanastomosis of the artery, but you'll also see how this artery here stays in situ. I can leave this part here where all these perforators are coming off of the P3 segment and going to the medulla, and I can leave them and protect them. So this technique is a way to protect those perforators and do things a little differently. Now, let me show you some examples of, again, these type 4 bypasses. And in this case, I'm going to do a double barrel bypass for this very dolichoectatic MCA aneurysm. And what makes this a type 4 bypass is that, you know, if I just did a double barrel STA MCA bypass, that would be something that I think we're all familiar with. And you can see it here. But what I'll do next is I'll use these ends of the middle cerebral trunks and I'll bring them together. So once I've trapped the aneurysm, I can cut them both free and I can create this middle communicating artery. And that middle communicating artery allows the bypasses to then distribute their flow throughout the middle cerebral territory, depending on the demand. If you look at these tissues here, the trunks coming out of this aneurysm are enormous. And the STAs are pretty diminutive. I mean, they're pretty standard in size, but relative to how large these recipients are, you can see the mismatch. Here's one, here's the other over here. They've both been revascularized, but this next step is going to be to create this middle communicating connection. So first I have to trap the aneurysm. Now that the aneurysm is trapped, I can cut free the temporal trunk, I can cut free this frontal trunk, and now I have 2 stumps that I can join together. You can see these enormous M2 segments. This is going to be a type 4A technique because you can see here, this is an end-to-end anastomosis, but I'm sewing it intraluminally. Here we continue, and you can see this is a type 4B bypass as well because it's a end-to-end anastomosis, but it's a reimplantation of these ends to one another. So it's an unusual way to do these reimplantations. So this is our middle communicating artery here. You can see the icy green, one bypass here, the other there, and the flow around the communicating artery allows this distribution of flow to find its way. So I've shown you this case. I'll skip it, and I'll just jump to this case here. This is another middle communicating artery for yet another deletoicatic MC aneurysm. You can see the aneurysm anatomy here. There's a trunk here and a trunk there. And what I'm going to do for this, I'm going to show you the use of the A1 over here as a donor site. So this becomes our donor. We're going to put a short jump graft that goes from here over to the M2. And then, like what I just showed you with that double barrel bypass, I bring the ends together and I form that middle communicating artery. And that allows the bypass to then redistribute the flow. So here now we're in the Sylvian fissure. I'm looking at the back underside of the aneurysm. Here's our anastomosis to the A1 segment. This completes our anastomosis. And then we can run the other end of the graft up to this M2 temporal division. There's the completed anastomosis. And so now we have our jump graft in place. And so in order to revascularize the other frontal side, we've got to free this trunk off of the aneurysm, which you can see here as it's being transected. And then we've got to do the same for the frontal division. We've got to free that up. And then I'm going to bring these together in an end-to-end anastomosis. And what you'll see is that even though I've dissected these arteries free, there's still a fair amount of tension. It takes a little bit of work to get these two stumps of the artery together. But you can see with a little gentle coaxing, they'll come together. And here is the that intraluminal suture technique, making this a type 4A and also a type 4B. You can see how we have to really carefully place each bite as we sew down that suture line. But here, after sewing both suture lines, you can see the end-to-end anastomosis here. Here's the reimplantation.
John, you may please mute.
Here's the jump graft here. Here's our anastomosis here, end to end. And you can see a nice filling of the MCA territory. So this is basically another example showing the use of the A1 as our donor site there. You can see an overview of that construct with our end-to-end here. And this is our angiogram post-operatively. So those are the things I wanted to tell you. It's really about, again, evolving the bypass craft. I've shown you different examples of that. This is a slide that just is a list of all of the crazy bypass ideas that I would love to try. I haven't done many of these, most of these. But, you know, the sky's the limit. I think all of us have different ways or different anatomy that we come across, and if we're creative and we are a little bit daring in what we're willing to try, we can create these very elegant constructs. It does require going to the anatomy lab, doing cadaver dissections. This is an illustration just to show you how, you know, when we were thinking about some of these bypasses, we would do studies to see, can the anterotemporal artery reach the A2 for this ATA A2 bypass? We have to test it out in the lab. We don't want to get into the operating room and think we can do something and find that it doesn't work. So these are all examples of ways in which we have to prepare. Let's see. I'll show you one more case. This is just an example of a dream bypass. You know, I'd never done this before. This was an unusual case of a distal aneurysm here and a unique double origin of pica. So there was this extradural caudal branch and this intradural rostral branch. They came together at this confluence, and the aneurysm was just distal to that. And so if you look over here to the right, we can repurpose one of those limbs as an intracranial jump graft. So we can cut it free from the vertebral artery. We can reimplant it here on the distal pica, and then it serves as its own jump graft to reconstruct the pica. So I'll show you that case. Oops. Here's that case. You can see the anatomy. There's the aneurysm. Here's our animation showing, again, this fusiform distal aneurysm, this double origin of pica here. We can isolate that proximal limb. We can free it up, swing it over to the distal pica and sew it in, and then we can trap the aneurysm. So here we are intraoperatively. This is one origin of pica. Here's the other. There's the confluence there at the bottom of your screen. And here's our aneurysm. If you look here, there's clot over the aneurysm. I thought maybe I could clip this, but you'll see that this is a true dissecting aneurysm. It just doesn't take the clip, and it ruptures intraoperatively. So we have to then trap it and escalate to the bypass. Here's a view just showing how that aneurysm is simply a hole in the artery. But now this is the proximal origin of pica, and I'm transecting it here. You can see how it flips nicely over to the distal pica. We can fish mouth the end of that artery. We can make a nice long arteriotomy in the distal pica. And this becomes an end-to-side reimplantation of one of those two origins of pica. So it's not what I would call a type 4 bypass, but it is what I would call a dream bypass, because I'd never done it. No one's ever reported that in the literature. And it's an example of how we can come up with something unique just by applying some of these principles that we've been talking about. So let me finish. I'm going to jump ahead here and show you this slide. I showed this to you at the beginning. This was, I think, a little bit disheartening to see that. But I wanted to end on a more positive note. If you look at the graph for bypasses broken out year over year, you can see that the line looks a whole lot better. We're actually on the upslope and increasing in our volume. And if you look over here too, we're not doing so bad with AVMs and cavernous malformations either. So I think there is a lot to be thankful for. It's an exciting specialty that we're in. You know, I think what this, what bypass sends as a message is that, you know, even with something as simple as just suture and good instruments, you can be innovative, you can be creative. It doesn't require high tech. You can do these very elegant arterial reconstructions, and you can really be creative and innovative. It does require a lot of work. I would stress to all of the younger neurosurgeons that it's about hands, head, and heart. You've got to work on your dexterity, develop your technical skills. You have to think through the strategies for these tough cases, use your creativity and judgment, and also heart. You know, what I'm recommending that you do is to really stick your neck out. These aren't the standard bypasses. You may have complications. There may be failures. It does take a lot of guts to really pursue this pathway. But, you know, when I think about the cases that I like the most to do and that get me excited, it's these cases. I really love them, and I think they really challenge me as a surgeon, both on the well, on all three of these, technically with the hands, the head, and the heart. You've got to think it through, you've got to execute, and when the going gets tough, you have to have the grit to make it through. It's 8:45 in Phoenix, and I think I've spoken for close to an hour. I wanted to save a little bit of time for some Q&A. So again, thank you, Raja, for having me. I apologize for my late start, but really it's been a pleasure to be here with you all.
Thank you. Thank you very much, Professor Lawton, for this incredible presentation. It was really amazing, the things that you can do with the bypasses. Are you there, Professor? Hello? Hello? Are you there, Professor?
Dr. Ben?
Hi.
Professor Ben, are you there?
Yeah.
Please come.
Okay. Very nice presentation. Professor Lawton, are you there?
You're looking for Professor Lawton. I think it's got disconnected, I think.
So,
Disconnected?
Yeah, it seems so.
Yeah, I think so too. Oh, well, we can discuss. Go ahead, Raja.
Yeah, Professor Ben. Yeah, it was a pretty exciting lecture. Actually, we never expected we could achieve this kind of things in brain. And he's rightly written in the book, if you read the preface of the book, 7 Bypasses, he's the author of the trilogy of 7 aneurysms, 7 AVMs and 7 bypasses. In his preface, he has written how he achieved this feat of from a novice to an expert, how he started, and it is very nicely written. I recommend everyone to read that preface of the book, 7 Bypasses. We really think that he should come back and take some questions. Yeah, Professor Lawton is here. Professor Lawton, can you hear us?
Yeah, I hit the wrong button. Sorry about that.
We understood. Glad you're back. In the last slide that I always remember, such landmark slides you showed in Mumbai, that in a war, everyone is afraid. But it is when you override your sense of duty that you really win. That was an excellent slide that you showed in the conclusion of your lecture in Mumbai. Thank you very much, Professor. On behalf of Professor Yoko Kato, I sincerely thank you for accepting our invitation. Now we can have some Q&As. Professor Bin, can you do you know Professor Bin is I must be so familiar to you, Professor Lawton. Do you know Professor Zubin?
Yeah. We met in
Yes.
San Francisco 18 years ago. Yeah. So Professor Lawton is he is one who inspired me to focus on the vascular surgeries. So after I came back to China, I focused on the vascular surgery. So Professor Lawton, yeah, can you ask some questions? Answer some questions?
Yes, of course.
Okay. I noticed that there's a lot of plaques on the vessel wall. So is this bother you to make the decision sometimes? And I noticed that in some cases, you made the bypass on the on the place that there's no plaque. So what is plaque? Sometimes maybe do some. Is there any cases that you can do the inductomy?
Yeah, that's a great question. There often is plaque on the artery. It's usually on the recipient, because the recipient, you only have so many choices where you're going to put the graft. And if it's plaque on the donor, you can usually trim it away and get to some fresher, more normal appearing tissue. So I obviously try and avoid sewing into plaque, but sometimes, you just have no choice. you can't move the artery or you don't have extra tissue to allow it to move any further. So my view on that is that as long as the intima is well taken care of, and as long as your bites in the rest of the wall are good and strong, you can sew into plaque, but obviously it's not ideal. And there are other cases where the plaque is so severe that you have to do an endarterectomy. I have a great video of a V3 vertebral artery to AICA bypass. And when I went into the V3 segment, which, as you know, is just that short segment back in the suboccipital triangle, there was a big plaque. I had to do an endarterectomy first to clean it out and then sew in the graft. So you can do that in some large vessel bypasses, but for the very small intracranial vessels where there's just little spots of plaque, it's often very difficult to do an endarterectomy and not damage the wall to the point where it'll compromise patency.
Okay, great. Thank you.
And I just want to say that, you know, Binju is one of my heroes, because I don't think there's another person in the world who's done or who does as many bypasses as he does in the course of a year, and who will ever do as many. I view him as it would be the, who's the home run king now? It's the Barry Bonds, the Barry Bonds of baseball. Binju is the Barry Bonds of bypass surgery that I don't think anyone will be able to catch.
Thank you, thank you. You are my hero, you know. When I see you in San Francisco, so I made my decision that I should do the vascular, I should be a vascular neurosurgeon. So you are inspiring me always. Yeah.
Thank you.
Thank you.
Okay.
Professor Atul Goel is in the crowd. Professor Atul Goel, would you like to come in, Professor? Professor Atul Goel. Yes, please, Professor.
Show there is no question, but you know what? All this requires very concentrated hard work over a lifetime, work in the cadaver lab, working with dissection, working with mouse, working with rabbits. It just does not come like that. You know, it is hard work, and it is persistence, and it is patience, and also it is talent. You see, after all, you have to be, you know, you work hard, but you have no talent. So Mike, what you have shown is an amalgamation, a mixture of hard work, persistence, patience, opportunity, and result. And my absolute, you know, congratulations to you and to your team, and my best wishes for continued hard work and showing fantastic, fantastic results. And also, as you showed, the artwork of neurosurgery. Nice to see you, Mike.
Well, it's always great to see you. I completely agree with your comments. This is no easy task, but you know, Atul, as you know, you and I are the same because we love what we do. So all that hard work, all that persistence, all of that time spent practicing and working on cadavers, I think you and I have enjoyed it. I think all of the young neurosurgeons, they probably recognize how this is a real pleasure, a real privilege to be able to do it. So it has never felt like work. And, you know, I think you're one of those who embodies this idea of evolving the craft, being creative, thinking outside the box, exploring new ideas, writing them up, and convincing the rest of us that you're right.
Thank you, Mike.
Thank you, Professor Goel, for joining us. It's indeed an honor to have you with us today.
An excellent surgeon like him would have had to go through to achieve this kind of result. So always when we see these kind of lectures, it's easy to assume that these results come easy. But as Professor Goel pointed out, it is a result of a lot of hours in the lab, a lot of hours in OR, and a lot of heartbreaks. So that's one thing the young neurosurgeons would have to realize. Thank you very much.
Thanks, Ed.
Yeah, I
Yeah.
think if I can comment, I show you a lot of my trophy cases, and these are cases obviously I'm very happy to show and proud of. But I think, Ike, you're right. It comes from a lot of heartbreak and plenty of failures. Those are what I call our ghosts. The ghosts always are with you. They sit on my shoulder. They never leave me. They're the patients who I'm responsible for their debilitation or their death. And we never forget those patients. They serve as constant reminders that we're imperfect, that our ego can get too big, or that our hubris can be too strong. And we can't be numb to that. I think it's really important that that message be also sent. And you know, it's funny, I saw your text this morning. I was gonna reply, and then I went off for my bike ride and didn't get a chance. But you know, it just made me appreciate how guys like you and really all of the 170 or so who are on here, we all love what we do. We're sort of consumed. We live this profession. We live and breathe this profession. It rarely leaves our thoughts, and I think that's what's part of what makes us better surgeons, is just enjoying being swept away by it. You know, it's a passion. It's like a romance, and when you love it and you think about it all the time, and you find things within it that excite you or stimulate you or get you to be creative or expressive, I think it's more than a vocation. It's a real calling, and that's what makes it special. I appreciate that. You know, we are so happy to have visitors come. I'm glad you came and spent 2 weeks with Dr. Spetzler. We continue that tradition of welcoming neurosurgeons from around the world and opening our shop to show you what we do. And you know, even amidst the pandemic, we are continuing to do that, and hope that others will follow your footsteps.
Thank you, Professor.
Thank you. So nice.
Thank you,
so
Professor. Dr. Liu, are you there? Liu is my co-host today for you on behalf of the ACNS Education Committee. Liu, are you there?
Hello, Professor. Yes. Yeah. Hello, Professor. Thanks for the great lecture. I just want to find out from Professor, based on your experience, when you have a planning for bypasses, and how often does intraoperative finding change your plan, especially when you see perforators, because perforator usually hardly seen in the pre-op planning. Thank you, Prof.
Yeah. Well, I would say that the intraoperative findings affect the decision probably 100% of the time. You know, like there are some cases where you just know you're going to need a bypass, and so you know you can kind of just go in expecting to. But there are many cases, and I don't have a number for you, but it's a fairly large percentage where you go in thinking that you can clip an aneurysm, and something happens, and the aneurysm ruptures, the tissue falls apart, you lose a branch artery, and in those situations you have to quickly escalate to the bypass option. And it's so helpful to have thought about it in advance. So anytime I see an aneurysm that's not routine, I kind of, in my mind, begin thinking and planning for the bypass. That way, we all have experienced this. When you get into a complicating situation and you have to like think on your feet and escalate from something routine to something extraordinary, there's a tremendous amount of inertia. And if you've already made that leap in your mind and prepared for that, then it happens more easily. And in many of the cases, it has to happen. So I think it's a very useful thing to always go into a complex aneurysm case with a bypass strategy, because sometimes that will get you thinking about what you need to do to prepare the donor, or to prep another site, or to get a little extra exposure here or there. And then finally, you know, that final decision is really an interoperative decision that's based on the perforators, the pathology, and a whole host of things.
Thank you, Professor. Professor Lawton, in your own words, I would like
you,
to
Professor.
tell one in your article of intraoperative ruptures, you wrote, every surgeon must envision disaster in all forms, and he should have strategies to amend them intraoperatively. That is a sentence quoted in almost all the series of aneurysm fractures after you wrote that. Indeed, that is a golden words from you.
Thank you. Thank you.
Professor Hido,
glad to see you. It makes me happy to see you've been reading.
Definitely, I'll read most of all your literatures. Thank you for educating us. And your co-videos are fantastic and are again teaching us a lot of new things. Congratulations for those great co-videos that you keep on posting. Any words from Professor Hirohito Kimura, and we will wind up. Professor Kimura.
Professor Lawton and John and Professor Dr. Lager, and thank you for asking me. So I'm so impressed with your topic, cerebral bypasses for the treatment of a variety of difficult cerebral vascular lesions and big giant aneurysms. So this is one question. So Professor Lawton, may I give you one question? So yes. Even with your excellent bypass techniques and great surgical strategies, and the problem is that the perforating up branches of the coming out of the terminated arteries may be occluded in the late surgical phase. So how can you solve the problem? Do you use some antiplatelet drugs post-operatively to the patient, or something like that? Maybe the problem.
I think one of the most vexing problems that we still have is that we can do all of these beautiful bypasses and we can exclude the aneurysm. And if you, for example, on the basilar trunk have one perforator that occludes, you can end up with a patient that never wakes up. And it is a terrible problem. I haven't completely solved it. I've written about this a lot for flow reversal, in particular for the basilar trunk aneurysms, where it's really so devastating. I do think that we can help that problem by being more aggressive with our antiplatelet regimen. For those patients that I do flow reversal where there are perforators at risk, I will use aspirin and Plavix fairly aggressively in the postoperative period. I tend to, I treat everybody that's been bypassed with aspirin, but for the basilar trunk aneurysms, I put them on Plavix right after they wake up from surgery, and I think that that's something that can be done. It's not fail safe. You still get problems and complications, but it's one thing that you can do. And I don't know that there's a whole lot else that we can do, because there are going to be these large arteries that have perforators and stagnating flow, and they're just going to be at risk.
Yeah, maybe. Yeah. Thank you for your comments. So congratulations. So once again, thank you for your nice presentation. I also love bypass surgery, so I will follow you. Thank you very much.
Thank you.
Thank you.
Thank you, Dr. Kimura. So in that note, would rather wind up for today. On behalf of the ACNS Education Committee and the President of ACNS, Professor Yoko Kato, I would like to thank Professor Michael Lawton, who has accepted our invitation and gave us such a fabulous talk. Professor Zubin, are you here, Professor Zubin?
Yeah. Raja?
Professor Zubin, thank you so much for being here.
I have a good news for you and for Professor Lawton. Today we arranged the WeChat channel broadcast. So there's 1,300 audience in the WeChat channel.
Oh, great. Yeah. That's great.
Yeah.
Professor Lawton has a huge fan following. I remember he crashed the internet during Brazilian neurosurgery talk he gave recently last month. Around 4,000 viewers were there. And it was a great gesture.
That's great to hear. Well,
coming
thank you
online.
for that, Binzu. I appreciate the numbers. I like following the numbers. Thank you.
Yes,
Thank you.
you broke the record for neurosurgical TV also.
Thank you.
Thank you very much, Professor. Thank you, Professor Bin, for holding the fort and for us until Professor Lawton arrived. We are sincerely thankful to you for that. Please express our deep apologies for all those people who kept waiting. And thank you for all those people who waited for so long and supported our educational initiative of the ACNS. We hope you extend your support for us in the future also. Thank you, Professor Lawton. And my regards to Dana Murray, who arranged this talk, and we had a lot of communication between us. Please convey my regards to her, and continue our education endeavors in future too.
Okay, well, thank you. Raja, congratulations on a great event. And John, thank you for televising. And Binzu, always great to see you. It was a great event, and I would be delighted to join you in the future. So please consider that an open invitation.